Good morning. Thank you. So we'll actually be presenting two patients with isolated cytopenia, and I'll present the first one, and Dr. Basood will present the second one. So here we're talking about a patient who has low-risk MDS with isolated neutropenia. She came in for a routine check. She has a past medical history of hyperlipidemia, hypothyroidism, and ischemic heart disease, osteoporosis. All of them are stable and well controlled. She has an unremarkable family history. Physical examination is completely unremarkable. No lymphadenopathy, no organomegaly. And on laboratory evaluation, she has a mild anemia. MCV is 98. What is particularly prominent is her white blood cell count of 2.6 and her ANC of 0.9. So in summary, we have a 70-year-old patient who's completely asymptomatic with significant neutropenia. Taking a further history, she denies constitutional symptoms, fever, weight loss. She confirms that she, over the recent history, has had 2 bouts of upper respiratory infections. Excluded other causes of neutropenia, B12 and folic acid, collagen vascular disease, viral illness, medications as well. On bone marrow examination, she has a cellularity of about 25%, no significant blasts. Her myeloid lineage, however, shows a decreased myeloid cell number with mild dysplasia. Karyotype and FISH showed monosomy 7, del5q, and trisomy 8. There was no MGS performed. So in summary of this patient at this point, and looking at her prognostic score, you can see that she only has a mild anemia, and even her neutrophils are slightly above what is required for a score there. And because of the cytogenetics, which are poor, she has an IPSS R score of 3. So her conclusion, she has lower risk MDS. And here are questions that we propose for discussion. How do we manage this patient with asymptomatic MDS? Should we treat her with GCSF? And if we treat the disease, should it be conservative medical management? Perhaps she should have a stem cell transplant. And if it is offered and she refuses it, then what could we provide her? Should we perform NGS, and how would that help in our decision for what to do? And of course, if she is transplanted, how would we prepare her? And once she is transplanted, if so, how would we maintain her care? Thank you. So now I'll ask Dr. Basood to come up and present the second patient.
So good morning, everyone. It's a pleasure to be here. Today I will be sharing the case of a patient with lower risk MDS and severe thrombocytopenia. So let's get started. The story started in 2012. At that time, she was found to have mild asymptomatic thrombocytopenia. Over the next 2 years, her platelet count gradually declined, as you can see. A bone marrow revealed hypercellularity, a decreased number of megakaryocytes with no blast. Neither cytogenetic or genetic study were performed. And no diagnosis was established at that stage. In October 2015, the patient, at the age of 61, presented in our clinic with worsening thrombocytopenia and spontaneous hematomas. Her medical history was unremarkable, and she was taking Livial, which later was discontinued with no effect on the platelet count. Physical exam was unremarkable, with no splenomegaly. However, she did show evidence of spontaneous bruising. Laboratory tests revealed that platelet count was significantly reduced with no change in the hemoglobin or white blood cells. Chemistry panel was normal. So we rule out secondary cause of thrombocytopenia. A bone marrow analysis revealed a hypercellularity with a decreased number of megakaryocytes and mild dysplasia without fibrosis or excess of blast. Cytogenetics show a 20q deletion. These findings supported a diagnosis of a lower risk myelodysplastic syndrome. So during the following years, the patient remained clinically stable despite ongoing thrombocytopenia. She experienced occasional mild subcutaneous hematomas, but remained asymptomatic otherwise. During this period, the platelets count gradually declined, further reaching 45 and eventually 30,000. Other blood counts, including hemoglobin and white blood cells, remained within normal limits. We initiated treatment with steroids and later with rituximab, but both approaches were ineffective. Given her stability and lack of severe bleeding symptoms, no additional intervention were taken during this time. So in September 2024, 3 months ago, our patient presented to the emergency room with chest pain, shortness of breath, and signs of cardiac tamponade. She underwent a pericardiocentesis, which drained half a liter of bloody pericardial fluid. Following this, she was diagnosed with pericarditis and treated with colchicine and steroids, leading to clinical improvement. At this time, her platelets count had further decreased to 15 till 20,000. A repeat bone marrow biopsy show findings similar to previous evaluation, with no fibrosis observed. Molecular testing with next-generation sequencing identified mutation in SRSF2, ASXL1, and a small fraction of JAK2. Despite this finding, her IPSS-M score remained in the same lower risk category. And here we are with a 70-year-old patient and after a life-threatening bleeding. Here are the points that we would like to discuss. First of all, ITP versus MDS, which with isolated thrombocytopenia, are these distinct entities overlapping in the management? Second, what are the optimal treatment approaches that we have in this case? And what is the platelet threshold to intervene? What is the role of the TPA agonist, if any? And how should we manage patient with cardiovascular disease, patient after stroke, with coronary stent, or with atrial fibrillation, who needs to take a chronic treatment with antiaggregant and anticoagulation? Thank you.
Oh, perfect. Oh, that's great. Do you want to?
Which of our experts would like to start us off with the use of GCSF in an asymptomatic neutropenic low-risk MDS patient?
Okay, so the first case, I find it a bit unusual from the point of view of cytogenetics and the association with neutropenia, because if I understood correctly, there was -5 del5Q as well as trisomy 8. Why that combination I find unusual is the patient wasn't anemic, so the 5Q component wasn't the dominant one. So it probably was the monosomy 7 and trisomy 8. Of course, you see patients like that. Should they be given GCSF? I give them if they get into trouble, but only if they get into trouble. And this patient hadn't gone into trouble yet. And the neutrophil count was still 0.9, which is good enough. And I don't interfere until it's below 0.5. That's first case.
Okay. My approach to neutropenia is I don't prophylax unless they're getting regular life-threatening infections. And I'm sure you all know we see patients with neutrophils of 0.1 all the time and never get sick, and then patients with neutrophils of 0.6 that are hospitalized all the time. So it's more than just the number. But if they do get recurrent infections, I will use GCSF. I know in the aplastic anemia world there was a concern.
What dose? At what regimen? GCSF?
I use it at the lowest dose that maintains a neutrophil count that keeps them out of trouble. So typically aiming for 0.8, 1. So it might be twice a week, sometimes 3 times a week, but usually that's enough. I know there's this theoretical concern from the aplastic anemia world of using GCSF. I remember Elaine Sloan suggested that there was clonal selection for 7q with GCSF. I think that's been debunked. I don't think that's a real thing, so that wouldn't factor too much. And yes, I think NGS would help with regards to deciding about transplant because many patients do get upstaged. And the recent publication from in JCO from the European Bone Marrow Transplant Group suggested that a number of patients are upstaged with using the IPSSM from the IPSSR. And this patient, if she had unfavorable mutations that upstaged her, would benefit from transplant if she moves from the intermediate risk category to the moderate high risk category, at least from their decision analysis. So yes, I would do NGS. I wouldn't use Vidasa in the absence of excess blasts. Yeah. And I'll pass it on to
post-transplant?
So yes, I fully agree with everything what has been said already, but I'm not totally convinced that this type of patient with this kind of cytogenetics should be classified as low-risk MDS. This is a complex cytogenetics. This situation is quite rare. And before taking any decision, either transplant, GCSF, whatever, I would have tended to repeat the bone marrow aspirate or bone marrow biopsy within a month or 2, just to be sure that this patient do not evolve with a bone marrow blast that might be quite expected in that situation, and that we have made a bone marrow aspirate quite early in the disease, and we did not have captured that the disease is more aggressive than it is in reality. So before taking any decision in this kind of patient that do exist, I tend to watch and wait and repeat a few weeks later or a few months later. That is safe because the patient has only mild neutropenia that is asymptomatic for the moment, would have tend to repeat all the workup to be sure on the diagnosis.
Mm-hmm.
Thank you. And for the second case, management of MDS with isolated thrombocytopenia. Would you use thrombomimetics?
Oh, if I can make a comment on that one, because it's not only MDS and thrombocytopenia, it's MDS and thrombocytopenia and autoinflammatory disease, because the patient had pericarditis.
Right.
And I think in the decision process, this has to be taken into account. Because there's something that is not written on that slide is whether this patient should receive disease-modifying drug, including azacitidine, or I don't remember the age of the patient, or stem cell transplant.
70.
70. Okay. So it's highly dependent, of course, on the disease. This is a low-risk disease, MDS with thrombocytopenia, DELF20Q, that is usually the usual picture of this patient with thrombocytopenia. This is well known.
You are not concerned by the thrombocytopenia?
Yes, I'm totally concerned by the thrombocytopenia. But if the patient had only thrombocytopenia and the pericarditis was only is resolving, it's fine. You can give this patient thrombomimetics, of course. But if the patient is on steroid for a long period of time, and you might think of giving this patient hypomethylating agents that might be active on MDS disease, but also on autoinflammatory disease that are associated with the MDS. And if it's not effective, you can also think to stem cell transplant. So it's highly dependent. Of course, it's a provocative comment, but it's highly dependent on the way the pericarditis is currently treated and if it's symptomatic or not.
Yeah, once again, it's a very interesting case, isn't it? So in terms of association between del-20q and autoimmune disease, I have seen it, and it's not that uncommon with del-22q to get autoimmune disease. So in that regard, the first question was, why was immune thrombocytopenia purpura really autoimmune, and there isn't a good test for it? Or was it part of the MDS disease? And I think in this case, it was probably part of the MDS disease. The reason why I say that, the patient was given steroids as well as rituximab, and there was no response to either of those. So I think it was part of the disease. And then a few years down the line, she then develops inflammatory pericarditis, which again, as has been said, like described autoimmune disease in MDS about 40 years ago, and it is quite common. So pericarditis, pleural effusion is more common in chronic myelomonocytic leukemias than in del-20q, but well recognized. The issue about colchicine is quite interesting because colchicine is an anti-inflammatory drug, and as you will know, colchicine has a resurrection of interest because of inflammation in MDS, and there are clinical trials people are either doing or talking about using low-dose colchicine, same dosage as has been used in cardiac disease, which is 50 micrograms. So I think the fact that colchicine was used is quite appropriate, I think. The question which has been posed is it going to get better, or is another autoimmune disease going to flare up? And if it does, then is the treatment still continuing with what you are doing now, or should you be more radical at that time? I think I would be conservative for the time being. That's probably because of my age.
Yeah, it's also it's an interesting case because isolated thrombocytopenia with MDS is very uncommon as a presentation. It's like, I think, 3 to 4%. From a Greek
do you see these
registry.
patients?
Yeah, we see them, but they're not common, and they are sometimes hard to separate between that and ITP. I think one of my readings about this was that to differentiate them, one potential test would be, not that it's so readily available, is a thrombopoietin level that tends to be much higher in ITP. And also in ITP, your platelet count tends to be much lower than in MDS. And she presented with a moderate, thrombocytopenia, not severe. I think the tip-off that maybe this was MDS was, one, she's bruising disproportionately to her platelet count, which, you shouldn't see with a platelet count of 50 in most people, but she obviously had platelet dysfunction as a result of her MDS. Do I think there's a dangerous platelet threshold for transfusion? So, it's obviously a very controversial area. Nobody knows if people should be getting prophylactic platelet transfusions as outpatients. At our center, in patients not receiving chemotherapy who are outpatients, we do not routinely give prophylaxis platelet transfusions. We do use a lot of TXA, and there's a randomized trial that's going to be run in Canada of prescribing TXA versus placebo in patients with lower platelet counts with myeloid cancers to see if it makes a difference in bleeding. But we don't have the answer to that. And it's always really challenging when they have cardiovascular disease. At our hospital, we stop giving antiplatelet agents when the platelets are less than 30.
What's the approach with patients with cardiovascular disease and thrombocytopenia?
In what sense?
So for example, if they
regular
have-
patient undergoes catheterization, platelet count 20,000. He needs both anti-aggregating and...
Well, I don't know. I mean, I think this patient doesn't technically have cardiovascular disease. She has got pericarditis.
Right.
And her coronary vessels may be completely normal. So I think that's the distinction we have to make. But if your question is, if she had coronary artery disease and was thrombocytopenic, and would you give her antiplatelet agents, as has been said? I mean, I think there are now kind of guidelines, aren't they, for low platelet count and when you should or shouldn't use anti-aggregating agents. And I think some would say 50, some would say 30. But it is that sort of a figure. But I don't think this patient had cardiovascular disease.
No.
Dr. Oster is going to give us a follow-up.
Lionel, listen.
Maybe we could take a question while we're waiting?
Oh, thank you. I'm Deepak from Royal Adelaide Hospital. Could I please ask the panel whether you would put the patient on antifungal prophylaxis who has got long-standing neutropenia if you're not using GCSF?
Antibacterial prophylaxis.
Antifungal.
Fungal.
Antifungal prophylaxis, probably not. I wouldn't. Because she still had a neutrophil count of 0.9 and not many patients at that level get fungal infections, although I fully accept the premise.
Is there a threshold below which you would put that patient? I'm not letting you off the hook here.
Give a number.
No, I mean, I
Give a
think
number.
old rule from many, many years ago, probably before most people in this audience were born. There was a study done by a chap called Bellingham from University College in London, and that showed neutrophil count of 0.5 and 0.3, that they were the key levels at which both fungal as well as bacterial infections occurred, particularly 0.3.
Thank you.
Are we?
So with the first patient I presented, we have follow-up. If I can have slide in the next.
There should be one more.
Yeah, okay.
No.
Oh, this is the first patient.
one.
There was a follow-up slide.
Yeah, the course, it's called course.
Yeah, that's the one.
Right, it's probably
This is the patient, but move on. Okay, you can just tell and skip the slides.
I'm sorry?
Say what happened.
Just
Okay, so the patient,
tell what happened.
do you have it there?
Her misery.
No, it's not that one. Okay, so the patient actually deteriorated. A long time went on till she was actually treated. She went on for repeated second opinions, number of them. And in the meantime, she got worse. She had a repeat bone marrow biopsy. At that point, she had 10% blasts. She had cytogenetics, which was significantly worse, including P53. And she was offered a transplant at that point. She was pre-treated with Videza and with sabatolimab, and at that point, she showed signs of improvement. Later on, she then had again a relapse, and she was given venetoclax, and at that point, she was significantly improved. That's sorry about the slides. But
Okay, we can move on.
Okay, thank you very much.
Thank you so much.
Appreciate the experts.
Okay.